So there are frequent hypoglycemic episodes in a 2.5 months old child to the extent that the mother has been advised to feed the child every few hours if the child were to survive. So these hypoglycemic episodes are life-threatening for the child, worrisome situation for the parents. Good morning, everybody. So with the help of this clinical scenario, we are going to examine several competencies related to glycogen metabolism, associated diseases, associated laboratory parameters and their analysis, and some will be touching adaptation in the first state, and also we will be touching something about nucleotide metabolism and lipid metabolism. So diverse competencies through clinical scenario, early clinical exposure, and that also cuts across the artificial boundaries created. And that is something called integration as strongly recommended by National Medical Council. So clearly shows frequent hypoglycemic episodes that there is something wrong with the endogenous pathways of glucose production. And the pathways, as you all know, the endogenous pathways are two, which just just a minute, yeah, glycogenolysis and gluconeogenesis. Glycogenolysis is more important in the short-term cases for a very short term, and there also it is the liver glycogenolysis which is more important. Glycogenolysis occurs in muscles and in liver. And it is the liver glycogenolysis which releases glucose into the bloodstream. And that is very important because brain, CNS are heavily dependent, if not exclusively, very heavily dependent upon glucose. और अगर glucose नहीं होगा, hypoglycemia, and all of you know, it's a life-threatening state. So glycogen liver के अंदर जो है, it is somehow affected in this child, so that the glucose cannot be poured out into the blood circulation. A word about glycogen, it is extensively branched molecule, extensively branched, which is helpful because the glycogenolysis occurs from all the non-reducing ends. So process becomes very fast. So ये release होगा, and after that we are going to see it will form glucose. A word about glycogen, there are straight chain portions and there are branched portions. Straight chain formed by alpha 1,4 bond, branching by alpha 1,6 linkages. And gigantic molecule is it, but very few enzymes are required to break this extremely large molecule. First of all, glycogen phosphorylase, it comes into picture. It cleaves only alpha 1,4 linkages. Yeah, these arrows show. So alpha 1,4 linkage glycogen phosphorylase ने cleave किया, resulting in formation of glucose 1-phosphate. So glucose 1-phosphate will be formed initially. Action of glycogen phosphorylase is supplemented by debranching enzyme. Reason, glycogen phosphorylase cannot take care of the alpha 1,6 linkages at the branching point. So the action is supplemented by branching and debranching enzyme. As the name suggests, कि branching point पर alpha 1,6 linkage को cleave करता है due to its dual activity. We are going to omit the details. अभी यही इतना याद रखते हैं, ग्लाइकोजन फॉस्फोरिलेज ने ग्लूकोज 1-phosphate बना दिया, which will be converted to glucose 6-phosphate by a mutase enzyme. Mutases are the ones which cause intermolecular shift within the same molecule. Kinases, if you remember, intermolecule shift from one molecule to another. Anyway, glucose 6-phosphate ban gaya, which will be converted to glucose. And the enzyme here is glucose 6-phosphatase. So glucose 6-phosphate will cause release free glucose, which is which is released into the blood circulation, and that is responsible for homeostasis, glucose homeostasis, keeping the blood glucose 60 to 90, fall nahi hone deta. So this is the endogenous glucose production we had been talking about. Ab, agar this enzyme is deficient, glucose 6-phosphatase, ग्लूकोज नहीं फॉर्म होगा, ग्लूकोज 6-फॉस्फेट का एक्युमुलेशन होगा, तो इससे क्या होगा? Hypoglycemia, severe hypoglycemia, as we had seen in this patient. So this is deficiency of glucose 6-phosphatase. This is called von Gierke's disease, type 1 glycogen storage disease. The huge glycogen stores are present in the liver region. Glycogen break ही नहीं हो रहा. So this is a rare disease, 1 into 10,000 live births. वैसे other types of glycogen storage diseases are also there. उनका incidence 1 into 40,000 है. So this is relatively more common and relatively a more common disease. There are 4 or 5 cardinal features. I have written 4: hypoglycemia, hyperuricemia, hyperlipidemia, and acidosis. And of course, clinical sign is hepatomegaly, as I talked about. First of all, hypoglycemia, we have already discussed. Now we are going to examine biochemical basis of other changes. Why hyperuricemia is occurring? You see, glucose 6-phosphate enhanced HMP shunt, if you remember, it causes C6 को पहले C5 में convert करता है, isn't it? और फिर बाद में C5, C6 interconversion हो जाता है. So if C6, that means glucose 6-phosphate concentration is increasing, via this second phase of HMP shunt, reversible phase, C5 में convert हो जाएगा. C5 is ribose phosphate. And all of you know that ribose phosphate is a foundation on which ribose phosphate, it's a foundation on which purine ring is built up. De novo pathway. So increase in the purine nucleotides. So we have come C6 accumulation and we have reached till purine nucleotide increased formation. And what is end product of purine nucleotide degradation? It is uric acid. So C6, C5, purine, uric acid. So this is hyperuricemia. One advanced point, I'll talk in the end. Will you remind me? PRPP. So हमने फर्स्ट कार्डिनल उसको देख लिया, पहले 2 एग्जामिन कर लिए, हाइपोग्लाइसीमिया एंड हाइपर यूरिसीमिया. Why hyperlipidemias are there? Hyperlipidemia. This is what we are going to discuss first. Hyperlipidemia. You see, the patient is having hypoglycemia. This leads to decreased insulin secretion, of course, and activation of sympathetic nervous system. Both these, decreased insulin and enhanced sympathetic nervous system activity. They cause degradation of fats in the adipocytes. We will have to go back to adipocyte metabolism for a minute or two. All of you know that the adipocytes have got huge stores of triglycerides. Triglyceride stores, they are continually being produced with the help of an enzyme, acyltransferase, and they are continually being degraded with the help of an enzyme called hormone sensitive lipase. Now, an important point, hormone sensitive lipase, it is inactivated by insulin and it is activated by sympathetic nervous system. Shown in this slide, insulin is inhibitor of hormone sensitive lipase, sympathetic nervous system activity के साथ epinephrine, norepinephrine, they are stimulating the hormone sensitive lipase. तो अब क्या होगा? Decreased insulin, enhanced sympathetic nervous system activity, there will be activation of hormone sensitive lipase, more and more fatty acids will be produced. More fatty acids are generated, then can be converted to fatty acyl coenzyme anyway. अभी तक हमने ये देख लिया that free fatty acid concentration into the blood circulation is going to increase a lot. अब free fatty acid का जब degradation होगा, all of you know beta oxidation, acetyl coenzyme A, acetyl coenzyme A can of course go into TCA cycle, but this is blocked. Why? Insulin ही नहीं है. Insulin is a strong stimulator of this and various other factors also. TCA block हो गया. What are the other routes available? Lipid for fatty acid formation, cholesterol formation. तो ये दोनों हो जाएंगे और इससे फिर क्या होगा? Hyperlipidemia will be there. So this figure shows more explicitly fatty acids enter mitochondrial matrix acetyl coenzyme A, तो ये cholesterol fatty acid synthesis में जाएगा and that takes care of the third. Why there is hyperlipidemia? Because fat degradation in adipose tissue, increased fatty acid level, increased overproduction of acetyl coenzyme A, which will find its way into the lipid synthesis. Now we are coming to the fourth one, that is why there is acidosis. Let me go back. Acidosis. अभी हमने देखा था थोड़ी देर पहले एसिटाइल को ए इंक्रीज हुआ था, एसिटाइल कोएंजाइम में लिपिड फॉर्मेशन में गया था एंड ऑल ऑफ यू नो एसिटाइल कोएंजाइम में इज अ precursor for ketone bodies also. So ketone body formation भी बढ़ जाएगी. So this way, these are acidic product. So there will be acidosis. I have written lactic acidosis separately, but you know we can always write acidosis of two types, ketone body की वजह से और lactic acid की वजह से. Why I have written lactic acidosis? It has got a special reason also. Iska, the students make a lot of, that make mistake here. They tend to say that, I will show here, they tend to say that glucose 6 phosphate accumulation हो गया, वो ज्यादा बना देगा pyruvate और pyruvate से lactate बन जाएगा. To be taken with a pinch of salt or rather with a handful of salt. I would rather take it with a bagful of salt because this pathway is subject to meticulous regulation, PFK, phosphofructokinase, one of the most important regulatory enzymes in the body, pyruvate kinase. तो ये जरूरी नहीं है कि अगर ग्लूकोज 6 फॉस्फेट बढ़ गया तो वो बाय लॉ ऑफ मास एक्शन यहाँ चलाया जाएगा. That happens in the reversible pathways, not here. Rather, the reason for that I would say is, अभी हमने देखा था, glucose 6 phosphatase is an important enzyme not only in glycogenolysis, it is the last enzyme of gluconeogenesis also. तो अगर glucose 6 phosphatase inhibited है, gluconeogenesis भी inhibit होगा. And you also know that lactate is a dead end product. It can go nowhere else but ग्लूकोनियोजेनेसिस, और कोई इसके पास कोई रूट अवेलेबल नहीं है. तो ग्लूकोनियोजेनेसिस अगर इनहिबिट हो गया, ग्रेजुअली दैट विल रिफ्लेक्ट इन द increased lactate concentration, lactic acidosis. So the four cardinal features, I would stick to this figure 4 only: hypoglycemia, hyperuricemia, hyperlipidemia, and acidosis. So these are the four cardinal. Of course, hepatomegaly, huge stores of glycogen will be there. Right. So this, as we said, von Gierke's disease, it is called 1 in 10,000 live births. And this well illustrates, this disease very well illustrates importance of endogenous glucose formation. हम सब में, वी आर नॉट कंटिन्यूअस ईटर्स. अभी आपने मान लो ब्रेकफास्ट किया, लंच आप 2, 3, 4 बजे करते हो बिकॉज ऑफ योर क्लासेस एंड ऑल. तो फिर क्या होगा उस दौरान, अगर एंडोजेनस ग्लूकोज फॉर्मेशन नहीं होगा, हेपेटिक ग्लाइकोजेनोलाइसिस, देन व्हाट विल हैपन? डेथ में ऑकर इन अ पर्सन हु डज नॉट ईट एनीथिंग. तो एनीवे, so it's a very strong statement. Death within hours of last meal. वॉन गेर्केस डिजीज हमने अभी देखी, ये है आपका fasting, hypoglycemia, etc. And there are a number of other glycogen storage diseases also. Lot of other glycogen storage diseases are there. Just ये क्यों आ गया? Just yes. So in fact, glycogen storage diseases, as we said, hepatic form, myopathic form, generalized form. So what form it is? Hepatic form. It is a hepatic form. So some points we are going to revise. And of course, we'll talk in separate lectures. The myopathic form, muscle involved, because muscles also have got a huge stores of glycogen, but they do not contribute to homeostasis, glucose homeostasis, because they do not have this enzyme glucose 6 phosphatase. So with that, we finish now. Thank you very much. Thank you so much.